Good morning. I am Dr. Prashant Joshi. Today we will be discussing regarding most important topics that comes from the neurology, that is headache. So first coming to introduction, I will give you a small introduction regarding what is the most important headache, that is the migraine. Migraine is one of the common causes of recurrent headaches. And according to International Headache Society, the migraine constitutes 16% of primary headaches. The migraine afflicts 10 to 20% of general population. In India, 15 to 20% of people suffer from migraine. The migraine is underdiagnosed and undertreated. So, what I have seen, this is most common cause of primary headache is generally migraine. And as you can see, if it affects 10 to 20% of general population, so what the huge amount of the burden of the disease is. Migraine is usually the most common cause of loss of work days throughout the globe. In India, 20% of people suffer from migraine. So if 20% of 150 crores is suffering from migraine, you see how many number of patients there would be of migraine. And this number itself suggests that it is so much underreported and is underdiagnosed. A definition: migraine is a familial disorder characterized by recurrent attacks of headache, widely variable in intensity, frequency, and duration. Attacks are commonly unilateral and are usually associated with anorexia, nausea, and vomiting. So, any headache that is unprovoked or of familial type, which is characterized by recurrent attacks, variable intensity, frequency, duration, it may be a migraine. It is not necessary that it may be bilateral or unilateral, and it may not be essential that it is always associated with nausea and vomiting. It is a common myth that the basic cause for underreporting of migraine is that the people stick to the definition of migraine that it should be unilateral, it should be associated with nausea and vomiting, but it is not so. So, coming to the migraine triggers, it is first we have disturbed sleep pattern, we have hormonal changes, drugs, physical exertion, visual stimuli, auditory stimuli, we have olfactory stimuli, weather changes, hunger, and psychological factors. So, first coming to sleep patterns, it is usually said that a healthy sleep, a deep sleep is essential for aversion of migraine. The patients who have a sleep abnormality and they don't sleep properly, they usually complain of migraine headache the next day. Even I have noted that if a patient of unknown migraine is suddenly made awake from a deep sleep, he starts having the headache. So there must be some relation between headache and sleep. The hormonal changes. It is obvious from the fact that many a times the migraine is associated with hormonal changes because high incidence of migraine and high surges of peaks of migraine are seen in mostly females during puberty, menopause, or during their monthly menstrual cycles. It is called premenstrual migraine, but it shows that there is some relation between migraine and the hormonal levels in the body. Now, few drugs they also cause migrainous headaches. Many drugs they also cause migraine-like headaches that we will discuss later. Extreme physical exertion that is also associated with migrainous headaches. Visual stimuli and auditory stimuli. The patients of migraine they typically complain that they usually get headaches while they are in very bright lights or they have very bright sounds, very high level sounds. They suffer from migrainous headaches. And a patient, if gets a migrainous headache, he usually wants to settle in a room which has no light and which has no sound. Few types of smells, intense perfumes, intense deodorants, essence sticks, and few masala types of things. They also cause sudden headaches, and they are olfactory stimuli. The weather changes are also seen with migraine. There is one type of headache called as monsoon blue headache or monsoon migraine. The patient, before it starts rains and when the atmospheric pressure is very low, the patient suddenly starts feeling very tight sensation on his temporal sides of heads and as soon and severe headaches. But as soon as the rain occurs, the headache goes away. So it is either this is because of pressure changes which causes the nociceptors or the pressure receptors on the scalp to stimulate migraine still under study. Hunger is very deeply associated with migraine. If a person of a known migrainous disease, he starts working in the early day without having food or skips some meals, it usually precipitates the headache. So the patients of migraine are typically advised not to skip their meals and to have their lunch, dinner, and breakfast regularly. Psychological factors, they also affect the migrainous headaches. Migrainous headaches are usually precipitated by intense emotional stress and a high thoughtful process. So we see there are many triggers of migraine, including sleep patterns, hormonal changes, drugs, physical exertion, and all sorts of high visual, auditory, olfactory stimuli, weather changes, and psychological factors and hunger. So what I have seen is three or four main things that cause headache are: one is sleep deprivation, one is food deprivation, dehydration, and stress. There, I think they are the main ones. Now, typical migraine has four phases: prodrome, aura, headache phase, and postdrome phase. These phases are associated with classical migraines. Not all the migraines are classical ones. Majority of the migraines we see in clinical practice are common migraines. So first we will discuss regarding classical migraine. It has a prodrome. It has a wave premonitory symptoms that begin from 12 to 36 hours before the aura and headache. The predominant symptoms are usually yawning, excitation, depression, lethargy, craving, or distaste for various foods. It may last for duration 15 to 20 seconds. So, time before the classical headache starts, the patient usually gets various types of symptoms, which we call as prodromal symptoms, and these are the symptoms. This is followed by an aura phase. The aura is warning or a signal before onset of headache. The symptoms are maybe usually olfactory or visual or psychological. The patient may complain of seeing flashes of lights or zigzag lines or difficulty in focusing. The olfactory aura, the patients can have abnormal senses of smells. He may smell, he can hear a variety of sounds, but visual aura is most common. I have seen it in the most of the patients. It also lasts 30 to 15 minutes. And after this is followed by classical headache, which is usually unilateral. It is associated with symptoms like severe nausea, anorexia, vomiting, photophobia, phonophobia, or tinnitus. And the duration may last from 4 to 72 hours. So you see, the classical headache migraine, if left untreated, the patient can have headache for more than 2 to 3 days. It is followed by post-prodrome. Following the headache, the patient complains of severe fatigue, depression, severe exhaustion. Some patients feel unusually fresh, but it is rare. Majority of the patients they feel fatigued, depressed, and exhausted. The duration is from 4 to 2 days. So a classical attack of migraine, which includes a prodrome phase of 30 minutes, aura phase of 15-30 minutes, a headache phase that may last up to 72 hours, and a postdrome that may last 2 hours. So a complete 1 week of patient is lost if he gets a severe headache. So the headache burden on the society as converted to times of day work loss is very major. Another types of migraine are more common that are called as common migraine. If the migraine is an acute headache that is occurring less than 180 days per year or 7 days a month, we call it as an acute migraine. Majority of the migraines they get converted to chronic types of migraines. So we have a chronic classic, a chronic tension type of migraine. According to international classification given by Headache Society, Committee of International Headache Society, we have classified migraine as migraine without aura, migraine with aura, and complicated migraine. The pathophysiology of migraine. The migraine is because of disturbance of vasculature in the brain with stretching of the nerve receptors that are attached with blood vessels. As you can see from the picture below the slide, the intracranial or extracranial blood vessels they undergo vasodilation during headache and undergo vasoconstriction during aura. So, as soon as the headache phase starts, there is a severe phase of vasoconstriction, which is followed by another wave of vasodilation. This wave of vasodilation and vasoconstriction they give the pulsatile nature to the headache. The cause for this is still not known, but we have a serotonin theory which says that decreased serotonin levels are associated with migraine. So migraine may be associated with decreased serotonin, and few of the migraine attacks that have been aborted by infusion of platelets which are rich in serotonin and a specific serotonin receptors found in blood vessels of the brain. So you can see from the slide that as soon as the blood vessels are they undergo vasoconstriction, the serotonin released, it causes the waves of vasodilation, which causes worsening of the pulsatile nature of the pain. The diagnosis of migraine is usually made by medical history. The patients are advised to maintain a headache diary. Migraine triggers. Now, this is the most important part of headache management. A proper history of the migraine, the aura, the prodrome, and the precipitating factors and triggers is to be done so as to get a proper diagnosis. All patients are advised to keep a headache diary in which they note the headache, time and the day of the headache which they suffered, and what things they did before headache. This is very much important in maintaining the trigger history of the patient, and the person who sees the patient, who provides the care, is usually able to identify the triggers. Amongst investigations, the patients are subjected to EEG, a CT scan and brain, and MRI. The CT scan and the MRI of brain are advised to rule out any secondary cause, and EEGs are done to rule out epileptogenic migraines. But basically, migraine is a diagnosis of exclusion. All things, all CT scans, all EEGs are normal, then the patient can be given a probable diagnosis of migraine. The goals of treatment for migraine are to establish the diagnosis, to educate the patient, discuss findings, establish reasonable expectations, involve patient in decision making, encourage patient to avoid triggers, choose the best treatment, and to create a treatment plan. The long-term treatment plan of patient consists of reducing the attacks, frequency and severity of the attacks, number of the attacks, avoiding the escalation of headache medication, educating and enabling the patient to manage the disorder, and improving the patient's quality of life. The management consists of pharmacological and non-pharmacological. The non-pharmacological treatment consists of identification of triggers, medication, relaxing techniques, and psychotherapy. The pharmacotherapy consists of two parts, abortive therapy and preventive. Abortive therapy means once the patient has got the headache, now our primary aim is to abort the headache and make him headache free. And second part of the therapy is preventive therapy, that he may not have future headaches. Abortive therapy is generally non-specific. It consists of aspirin, which is 500 to 650 milligram orally, paracetamol, that is 500 to 4 gram orally. 500 milligram paracetamol can be given 3 to 4 times a day. Ibuprofen 200 to 300 milligram orally, diclofenac 50 to 100 milligram oral, and naproxen 500 to 750 milligram orally. These are the abortive treatments. Apart from these, injectable Tynapars, Voveran, injectable ketorolacs, and injectable morphine can also be given if the headache is not responsive to these oral medications. The specific treatments to abort the therapy are ergotamine, dihydroergotamine, triptans, of which sumatriptan, rizatriptan, and naratriptan are main. The ergotamine is given 1 to 2 milligram per day, maximum 6 gram per day orally. And dihydroergotamine is injectable, which is given as subcutaneous injections, 1 milligram to given 2 to 3 times per day. The sumatriptan is a preferred drug to abort migraine, but one thing regarding sumatriptan has to be kept in mind, that all triptans, they have a potential to raise the blood pressure. So any patient who is cardiac patient, who has suffered intracranial bleed, patients of SH or patients of old MI, they should be probably, or hypertensive patients, they should be avoided for sumatriptan. The sumatriptan is given 25 to 300 milligram orally subcutaneously or 6 milligram subcutaneously injectably. The rizatriptan is given 10 milligram orally, and naratriptan is given 5 milligram orally. The triptans can be repeated after 8 to 12 hours if the headache does not abate. The preventive therapy consists of propranolol beta blockers, which is given 240 milligrams per day, calcium channel blockers, which consist of verapamil and flunarizine, tricyclic antidepressants, amitriptyline, and SSRIs, fluoxetines. So these are the classical preventive therapy and abortive therapy medications. Now there are calcitonin gene receptor protein blockers that have emerged as a newer, of which is called as immunotherapy. And Rempagipant is one of the drugs that is used for this. Now, the migraine significantly interferes with patients' daily routine despite acute treatment. Acute medications, ineffective, intolerable, or overuse, the patient has to be given various types of alternative therapies again and again. The patients may have frequent attacks which are very troublesome. We have to consider uncommon migraine conditions. Also, while managing the patients, we have to consider the cost of therapy and the patient's interference. So, use preventive medications when needed, treat long enough, avoid acute medication overuse, take coexisting conditions into account, use drugs with best efficacy of the patients, always choose the drugs regarding the patient profile. For example, if the patient is obese, don't use valproate. If the patient is obese, then better drug will be topiramate that causes weight loss. If the patient is a female young patient, then avoid valproate. It may cause hair loss or weight gain. If the patient is a cardiac, then beta blockers are preferred. If the patient is suffering from comorbid depression, then amitriptyline or triptylines would be better. So in conclusion, the headache is more common in adults than children and in women than men. While researchers have some idea of what happens within the brain during migraine attacks, much remains to be discovered about its underlying cause and mechanisms. In addition, treatment focuses on avoiding those things that seem to trigger attack, identifying drugs that prevent or reduce severity of attack, and drugs that reduce intense pain of several attacks. The good news is that several classes of drugs are effective for different kinds of migraine, and most migraine sufferers can work with their doctors to minimize migraine effects. So this was all regarding the migraines. Thanks for joining. So you can ask any doubts later on.